Good morning. My name is Radha Sundram, and it is my privilege to give this lecture on diversity in donor panels for the Donor Research Network Symposium series. I'm a consultant in intensive care with NHS Greater Glasgow and Clyde in Scotland. I'm also a clinical lead in organ donation with NHS BT, NHS Blood and Transplantation in Scotland. I also have a training role. I'm the regional advisor for training in intensive care medicine in Scotland. In my role as a consultant in intensive care, I have the unique privilege of approaching families at end of life and actually exploring the donation wishes of the dying relative and facilitating donations and saving lives thereby. As a clinical lead with NHS Blood and Transplantation, my role and remit involves improving donation awareness in our multi-ethnic societies. The objectives of this talk are to explore the terms diversity, race, and culture, discuss the current statistics regarding donation and transplantation in the UK, exploring the issues with donation and transplantation in the Black and minority ethnic communities, a brief summary of how donation works in the UK, a detailed look at why family consent is pivotal to the success of donation and what factors influence consent from families. And we'll end with actually reviewing what's been done so far to improve diversity in donor panels and what still needs to be done. Diversity is the existence of variations of different characteristics in a group of people. These characteristics could be everything that makes us unique, such as our cognitive skills, our personality traits, along with things that shape our identity, our race, our age, gender identity, religion, sexual orientation, language, socioeconomic status, cultural background. Race is actually an ancient term, it's non-scientific. It's a political classification of human beings and is based on physiological characteristics such as skin color, eye shape, and texture of hair. Ethnicity, on the other hand, is a key facet of culture. It refers to a common ancestry, a sense of peoplehood, and a group identity. From a common ancestry and a shared social and cultural history, and national origin have evolved shared values and customs, and our public behavior, and our behavior in terms of health choices. Culture is defined as a specific set of social, shared, educational, religious, and professional behaviors, practices, and values that individuals learn and ascribe to while participating in or outside of groups with whom they typically interact. These definitions have been borrowed from the seminal work of Bomar and Friedman. But we know the truth is that our societies in the United Kingdom, Australia, Europe, and perhaps in the modern world is very, very complex. And there are many intersections. We're all shaped not just by our ancestry or heritage, but also by where we live, our level of education, whether we are deprived in terms of economic ability. And we make decisions about our health choices because of our culture, because of our ethnicity, because of where we live, because of our political views. And while it's really important to recognize that our societies are diverse, it's helpful to remind ourselves, using Simon Sinek's golden circle, why we do what we do. We're having these lectures and we do the work in improving diversity in donor panels because we want to ensure that people of all backgrounds and circumstances have access to the organ they need in a timely manner. This work is done by NHS BT, which is NHS Blood and Transplantation. It's a service and national service in the United Kingdom, which facilitates donation and coordinates transplantation. And we do so by informing, engaging, and empowering our communities. The deceased donor transplant rates in the UK in 2020 were 45.8 transplants per million population. This is less than Australia and far less than the United States, which is at 96.2, and Spain, which is at 86.4. What is noteworthy is that the United States of America is an opt-in system and Spain is an opt-out system. The United Kingdom very recently has moved to an opt-out system. The total transplant rates from living as well as deceased donors in the United Kingdom is at 54.3 transplants per million population. A very useful metric is utilized deceased organ donor rates. An actual deceased organ donor is one where at least an organ has been recovered for the purposes of transplantation, in contrast to an utilized donor who is an actual donor from whom at least one organ has been transplanted. The number of utilized donors is therefore lower or equal than the number of actual donors. The number of utilized deceased organ donor rates for the United Kingdom in 2020 was 17.4 donors per million population. Deceased donation rates in the United Kingdom have risen over the last 20 years because of the work of the government and NHSBT. They were sitting at about 800, but they have doubled in 2018 and 2019, but they did sharply fall to just over 1,200 donations per year in 2020 because of the pandemic. This has been because of an effect or impact on practices in intensive care units. It has also happened because of a will in society in the UK to actually accept donation and proceed with donation and transplantation. The blue graph, the blue line, actually is about referral rate. Referral is when an intensive care unit refers a patient on life support to NHS blood and transplantation for consideration of donation and transplantation. The pink line is that of consent or authorization. This is where families agree to proceeding with donation, and that sits at about 66%. The green line refers to the presence of specialist nurses in organ donation. These are highly skilled individuals who are part of NHS blood and transplantation. They're embedded in every intensive care unit in the United Kingdom, and they help facilitate donation, help support the family, and coordinate transplantation. And the presence of specialist nurses in organ donation and donation conversations has steadily risen over the last 10 years. These are the statistics from March 2020-21. The line at the top refers to the number of patients who are waiting for transplants. So in 2020-2021, there were over 4,000 patients waiting for a transplant. We proceeded with donations in 1,180 patients, and there were 2,947 transplants. There is still a gap between the number of patients on the transplant waiting list and the number of transplants that we actually were able to do. And sadly, this results in 3 people every day dying waiting for a life-saving transplant. If you look at the sources of donation or the types of donation, then donation after brainstem death continues to be the predominant source of transplanted organs. Living donors, the numbers have also increased. There has been a drop in the last couple of years because of the pandemic. If you take the UK population to be about 67 million and the death rate to be about 680,000, as we've said, that only 1% of deaths can proceed to donation because deaths have to happen in an intensive care unit to proceed with donation. The patient has to be on life support. So the number of potential donors sits at about 7,000. Of these, about 5,922 donors were actually referred to the NHS Blood and Transplantation Service. Donation requests were made to 2,248. There's a sharp drop here because once patients have been referred, the service may decline patients because of comorbidities or actually the impossibility of proceeding with donation. This number falls further to 1,635 because that's the number of patients whose families have agreed to donation. And the actual donors then were about 1,118. So this is a pool that's diminishing. And this resulted in 2,947 transplants. Why does it actually matter if the donor pool is less diverse? Why are we trying to promote the diversity of donor pools? This is because of a discrepancy in the non-white communities. And for the purposes of this talk and in the United Kingdom, the used term is Black and minority ethnic communities. If you look at the kidney transplant waiting list, or if you look at the kidney recipients, then up to a quarter of them are from the BAME communities, because diseases like hypertension, diabetes are more common amongst the South Asians and Afro-Caribbean populations. We know that it's easier to get a match if there is HLA compatibility. We also know that certain blood groups are more common in certain ethnicities, and your best match actually comes from someone who shares your ancestry. Longer waiting times for BAME patients are a direct consequence of two things. We have a high demand for organ transplants amongst BAME communities and a low consent rate and low opt-in registrations to the organ donor register. South Asian patients sadly wait 3 years for a lung transplant, whereas their white counterparts wait only 9 months. Black and Asian patients wait about 6 months longer than white patients for kidney transplants. This is the data that we have from the United Kingdom, England and Wales for our Black and ethnic minority donations. If you look at opt-ins into the organ donor register, the organ donor register is the register that patients can actually make an expressed wish to donate after their death. The opportunities they get to do this are when they register with a new family doctor or general practitioner, or when they sign up to get their driving license. They can see a public interest campaign and go on the website. But if you look at the organ donor register in the UK, only 7.8% of opt-ins are from the Black and ethnic minority communities. If you look at the opt-outs, so these are people who have actually gone on the register and actually expressed that they do not wish to proceed with donation when they are at the end of life. 74% of opt-outs are from Black and ethnic minority groups. But there is a discrepancy, with a third of patients on the waiting list being from Black and ethnic minorities, but actually only 7% of deceased donors being from Black and ethnic minorities. So we are overrepresented, Black and ethnic minority communities are overrepresented in ODR opt-outs, the waiting list, and deceased transplants, but are underrepresented in ODR opt-ins and eligible deceased donors. We've taken this sort of percentage of population to be Black and ethnic minority in England and Wales as 11%, as 14%, sorry, from a population estimate of 2011. We think that this number has risen in the last 10 years. If you look at the BAME ODR opt-ins, then 6.8% of those are Asians. If you look at the opt-outs, 45% of the opt-outs are from the Black and ethnic, from the South Asian communities. And this may be due to myths, might be due to ignorance, and might be due to health illiteracy, and we will explore those reasons later on. We have data from Scotland as well, and it's roughly the same, where the BAME communities are overrepresented in ODR opt-outs, deceased donor transplants, waiting lists, and underrepresented in eligible deceased donors and opt-ins. What is also more sobering is that while 75% of white families agree to donation, only a third of BAME families agree to donation. And this results in longer waiting lists for BAME patients, because 1 year after being listed for transplantation, 70% of BAME patients are still waiting for a transplant compared to 52% of white patients. In the UK, a patient presents to their primary care practitioner and then may be referred to hospital when they have organ failure. They may end up in hospital on life support when they can proceed to donation. Their donation can save up to 8 lives, and those 8 lives may be of patients who have again presented to primary care and then secondary care with chronic organ failure. This is coordinated by NHSBT. NHSBT is run by NHS Blood and Transplant, There are 12 regional teams who are responsible for facilitating organ donation in each region. Each intensive care unit has an embedded specialist nurse and a clinical lead for organ donation who are responsible for supporting and promoting organ donation within that unit. There's huge will in the society in the United Kingdom towards support for organ donation. In various surveys and polls, 99% of the British public would accept a transplant if that was their only chance to save their life. And over 90% of them would support donation. But if you look at the organ donor register, the highest registration is in Scotland, which is only at 52%. The UK moved to an opt-out system because of huge societal investment in donation and political will. Nobel Prize-winning economist Richard Thaler wrote a seminal book called Nudge, where he talks about choice architecture. He talks about changing the system to help people make the right choice. It might be to do with environmental sustainability or climate change, or it might be to do with organ donation. If there is huge societal acceptance of donation and transplantation, then an opt-out system will afford ease. Most people don't sign up to the register because death is an abstract thing, and although they support it, they just haven't registered. The legislation has changed in Wales in 2015, and this resulted in a family consent rate from 47% to over 70%. It changed in England in 2020 and in Scotland last year in 2021. The law in England is called Max and Kira's law. Max Johnson had chronic heart failure. He was saved by the generosity and bravery of Kira Ball's family. Kira was a young child who was in a road traffic collision, and her heart was transplanted into Max Johnson. You can see Kira's dad listening to Kira's heart within Max. Max and Kira's family tirelessly campaigned for a law change. It's also interesting to see how the law change happened in the UK. It came about as a result of a private member's bill, and the private member was a Labour politician. The actual majority party in Parliament at that time was the Conservative Party. But because there was so much societal support and political will, despite the fact that it was cross-party, there was acceptance and the legislation moved forwards. Donation happens at end of life. In the UK, when we reach fertility, there is a consensus decision. A consensus is reached amongst all the healthcare professionals looking after the patient that it's time to change the focus to comfort and dignity. At this point, the consultant in intensive care approaches the family with a specialist nurse and sort of seeks their opinion or views on organ donation. The family, though, have to consent or authorize for us to proceed with donation. With the law change, there has been a subtle reframing of the conversation that we have with families, whereas previously we asked them whether they were aware of the dying relatives' wishes about organ donation. We now ask them whether they're aware of any objection to donation. While this might just seem like a rearrangement of words, it's actually a very powerful tool in reframing the conversation and the way the families approach it. The UK have a soft opt-out system, which means that we don't proceed with donation if the families say no. The law has actually, although the ODR opt-outs are because there are myths that the state now has control over people's bodies, the opt-out law actually protects the patient. It's a fantastic piece of legislation which has laid out clearly and unambiguously consent, futility, the legal determination of death, and also gives sanction for pre-transplantation tests and checks. It also clarifies which family member or next of kin is approached, and what the hierarchy of these family members may be in a family setting, certainly when there's dissent. Because of a large number of refusals for organ donation, particularly in Black and ethnic minority communities, it's important for us to analyse the factors that influence consent. And you can see from this graph that 25% of refusals are because the patient previously expressed a decision not to donate. And 14% are because the family are unsure about their relative's wishes. 10% is because the family did not want surgery to the body. And in 13%, it's because of the length of donation process was too long. This has particular relevance for our patients from Jewish and Muslim backgrounds, because the Abrahamic religions require for the last rites to be done within a particular time frame, within 24 hours. However, we find that having open and honest conversations with the families and giving them an honest view of how long the donation process is going to take place often helps persuade them to make a positive choice where donation is concerned. If you analyse the factors that actually influence consent, ethnicity plays a big role, and consent is less likely in patients from BAME communities. It's less likely in more deprived groups. It's more likely when the patient has discussed the donation decision with the family, or if they're on the organ donor register. We find that if the patient is on the organ donor register, then it's a powerful persuasive tool in actually giving the family courage to proceed with donation. Consent is more likely for male patients. Consent is 80% less likely in Muslim patients. And there are different results for donation after brainstem death and donation after cardiac death, and it's more likely for neurological cause of death. The barriers that actually prevent donation, reasons for families saying no, could be a deep mistrust for the medical establishment. This is quite common because of historic inequalities in our healthcare system. It may be because of religious and cultural factors. It may be just because of a lack of information. It might be because they are worried about surgery or mutilation to the body. But most often it's because they're unaware of their loved one's wishes. And at the time of their greatest grief, they don't feel able to make such a big decision. We have now included a faith and beliefs declaration in the organ donor register, and patients can tick this. This helps inform the patients and their families that we care about their culture, about their religion, and the impact it may have at end of life. It also helps the teams to have prior warning before approaching these families, so that we can approach the families with cultural sensitivity, that we can engage faith experts, so that we actually have use the right language, allay their fears and apprehensions, and have an effective conversation with them. Over the last 10 years, we've worked very hard to improve diversity in donor panels. We've done so by public information campaigns with more representation from Black and ethnic minority patients. We've produced faith leaflets and leaflets in many languages. We held the first faith and organ donation seminar in 2015 in Scotland, and was previously held in England as well. This gave an opportunity for healthcare professionals to seek the views and support of faith leaders. A fatwa has been rewritten in the UK to support donation for the Muslim communities. We've held workshops with imams. We have a Jewish organisation called JODA in the UK that works with Jewish communities and improves organ donation awareness. There has been a huge amount of funding for community investment schemes, and these projects range from cultural activities promoting donation to hairdressers in Black and ethnic areas promoting donation. We have a number of media campaigns. We have worked with charities like Kidney Research UK and helped peer educators who are community educators actually improve donation awareness in their communities. The law has changed, and we have recognized the importance of faith and beliefs at the end of life with the law change and with the faith and beliefs declaration in the organ donor register. What hasn't changed has been the strict adherence to processes and governance. What hasn't changed is a compassion and sensitivity in approaching families. What hasn't changed is keeping the family at the epicenter of these conversations. As I say, the UK has a soft opt-out system. We recognise that these bereaved families are grappling with an avalanche of grief. And the last thing we want to do is disenfranchise them by actually going against their wishes. We find when approaching families that if their dying relative has discussed donation or has actually gone on the organ donor register, it gives them comfort and courage to proceed with donation. Organ donor registrations in Scotland are high at 51%. The opt-out in Wales is 6%, but in Scotland's about 3%. And if you look at consent or authorization for donations, then expressed opt-in, which is the blue horizontal bars, are the most important in actually securing the family support. Over the last 5 years, we have seen an increase in transplants for BAME patients. We haven't yet seen a change in BAME living donors or BAME deceased donors. We have worked with the Scottish Government and Kidney Research UK in promoting organ donation awareness at every level. At the level of schools, we've improved the messaging, we've improved awareness, and we also are trying to ensure equity of access at end of life. We've also tried to work with primary care to reduce the need for a transplant. Using our peer educator project, we've encouraged conversations amongst diverse groups. And with the pandemic, we've actually exploited the use of digital platforms, having had more than 40 webinars with various faith groups on the law change and donation. We find that public information campaigns or media campaigns, although they generate an understanding, communicate a message, it does segment and target different audiences. However, seeing donation promotion awareness as a social movement is more effective. It's almost like how communities came together at the start of pandemic or with climate change, because bringing communities together unifies disparate audiences. Because organ failure doesn't discriminate. And it creates a cause, and actually action is success. We find that working with communities, having an intentional relationship with them, grounded in shared values, with a mutual exchange of interests and assets, results in growth and learning, and not just helps them, but helps us inform our campaigns, inform our approaches. We still urge everyone to actually make a choice and express their donation wish on the organ donor register. Where do we go from here? We need to change the narrative. We need to recognize the detrimental effect that historical inequalities has in terms of mistrust of the medical establishment. We may have to rethink the use of the term BAME. By lumping all the non-white communities into one group has helped collecting of statistics, has helped data collections, and has helped our awareness work. But what we failed to do is actually recognize the unique differences in that heterogeneous group. And maybe race isn't the determinant after all. It might be culture, it might be ethnicity. We need to be better at providing unconscious bias training for healthcare providers, so that healthcare providers seek forgiveness rather than permission, are curious and empathetic rather than presume and avoid. We need to celebrate donation rather than focus on the transplant recipients, and provide equity of access in terms of patient-centered end-of-life care. Diversity in the UK is increasing and the world is changing. We have champions of diversity in the UK who are speaking up for different sections of society. Marcus Rashford, Man United's footballer, who actually campaigned for meals during the pandemic for school children. Prince Harry and Meghan Markle. We need to recognize that actually the landscape is changing. The take-homes and messages that I would like you to take away is that it is still a work in progress, and there's still recognition that there is a need for awareness in the BAME communities. But what I would like to emphasize is that the barriers in these communities are not to donation, but revolve around understanding of end of life, determination of death, reconciliation of cultural norms with medical processes. Language, not data, is key, and it's been a huge privilege to be a part of this work. I've been doing this work for over 10 years. I started doing it actually in 2008, and would often quote a statistic and say that, which is true, that it'd be 5 times more likely to need a transplant than to be in a position to donate. And when I started doing this work, I had an interest because I was an ICU doctor and because I was from the BAME community myself. But what I didn't actually appreciate was that I might need transplants one day. So I started this work in 2008, but in 2015, my vision started deteriorating. And it was the only solution for me was corneal transplants. But thankfully, because of the generosity and courage of 2 families who during their greatest grief said yes to donation, I received corneal transplants in 2015, which has enabled me to continue to do my work in intensive care, work through the pandemic, be a frontline worker, be a mother, be socially and economically productive. I don't know whether this could be called a conflict of interest. I'd like to see it more as an advocacy. And my gift of sight has not just transformed my life, but has actually consolidated my desire to keep doing this work. I'd like to acknowledge Becca Curtis, Sue Madden and Dale Gardner of NHSBT for all the slides on the data in the UK. They do an amazing job in the statistics department of NHSBT. I'd also like to acknowledge the sterling contribution of Linda White, a civil servant in the Scottish Government. I'd like to thank Susan Hanna, who's the regional manager for NHSBT in Scotland. This is my email address, and I'm very happy to receive any questions. Thank you.